Move to our next presentation. By Dr. Gabriele Gasparini, and from Italy, he will talk to us about a talk that titled Trust the Investment.
So good afternoon, everybody. First of all, I would like to thank the GIS president for kind invitation. For us, it's a great honor for me to join you, and congrats for such an amazing event. So I'm going to talk about the investment in terms of the investment procedure that we take in consideration during chronic total occlusion revascularization. So if we look the global chronic total occlusion crossing algorithm, you can appreciate that the second last step before considering stop the procedure or failure of the procedure, it's called investment procedure. It's a pretty new concept in the CTO field, and I try to show you exactly what we mean. So the concept is that in case of failure of all the previous technique in terms of antegrade wiring, antegrade or retrograde crossing, a subintimal plaque modification could be taken in consideration to restore the antegrade flow, and this can facilitate subsequent lesion recanalization. This is the concept of the investment procedure. So this investment procedure allows for the CTO vessel to form an antegrade pathway, an antegrade tract that can be successfully wired in a subsequent procedure and let also the side branch region to heal over time. So the concept is first prepare the vessel in the investment procedure, then stent the vessel in a subsequent procedure. And I show you just a 3 case that was performed in 3 different interval of time, because the suggested period between the first procedure and the second one should be more or less 8 weeks. So I show you 3 different scenarios. This was RCA CTO. It was attempted, of course, an antegrade wiring, but after a failed attempt, we decided to go on with some additional technique to solve the proximal cap ambiguity. So we did this antegrade knuckle wire to do some antegrade preparation and to be ready for retrograde crossing and for retrograde connection with antegrade guide wires. But after that, we were able to cross retrogradely the occlusion, but unfortunately, we created a dissection with the retrograde guide wires. So we decided to switch once again to antegrade and to do an investment procedure. Investment procedure is an evolution of the STAR technique. So you should advance your antegrade wire in a STAR, in a knuckle fashion, to intentionally dissect the vessel. So this is what we did. We advanced a gladius mongo antegradely in a knuckle fashion, and we reached the distal PDA. Then we dilate the entire course of the vessel, and this was our final result. The artery was completely dissected as expected, because it was intentionally an investment procedure, and the procedure was done in February. So, of course, after 8 weeks, it means that the patient should come back in April. And this is what we found in April. The artery was completely open, and from this other view, you can appreciate this side that was the previous CTO body, with this good pathway between the proximal part and the mid part of the RCA. So 7 weeks later, this was our findings. We wired without any problems, and we stented the artery, achieving this result. So this is a summary of the first case, what we had, what we left, an artery completely dissected, and what we achieved after 7 weeks. The second case is quite different because some delay in having back the patient in our cath lab. It was a very long RCA lesion of a huge dominant RCA. We tried antegradely with the move the cap technique with the base and then the Carlinos. You can appreciate that we dissected the antegradely in order to understand where the vessel course is. We advanced the gladius MG in a knuckle fashion, and then we were ready to go retrogradely for the reverse cart. But unfortunately, there were no septal connection. We test all the septal. Then we decided also to try this epicardial collateral connection, but it was not possible to cross this collateral connection. So we switched once again an antegrade fascian, and we perform a knuckle and a star technique in both vessels. PDA, you can appreciate the first guide wire that was advancing in a subintimal fascian into the PDA, and then we did the same into the posterolateral branch. We dilate both branches and all the vessel cores, achieving this final result. So after that, of course, you should plan into the next 2 months the second procedure to finish the recanalization, but it was planned during Christmas time, so the patient preferred to postpone. Then in January, the patient get COVID. So finally, he went back after 22 weeks. It means more or less 5 and 6 months. And this is what we found. The artery was totally occluded once again, but our investment procedure was effective. Our previous job was effective and useful because we already create a pathway. So advancing at an antegrade guide wires, this was a Gaia, we were able to find the same pathway of the previous procedure. We reached quite easily the distal cap, and we crossed into the distal true lumen without any problem. So the investment procedure was effective in terms of creating a pathway. Then, of course, we dilate and we stent the vessel. This contrast staining was due to an aggressive post-dilatation in the mid part of the RCA. So what we had, what we left, and what we achieved after 22 weeks. And the last cases, it's the last that I did 1 or 2 weeks ago. This is another RCA lesion. We try antegradely, no way to cross antegradely. We try retrogradely, some septal connection, but unfortunately, during the retrograde attempt, we dissected the connection and we created a communication with the coronary sinus. So the only way was to come back once again to an antegrade approach. And so in this case, we did another investment procedure. We dissect the vessel. We reached the posterolateral branch, and then we did the same into the PDA. We dilate all the vessel, and this was the final result. But during the hospital, so the patient was scheduled for the second procedure after 8 weeks, but during the hospitalization, the patient had angina. So we did, during the same hospitalization, the revascularization, you can appreciate after 5 days, 4 days, the same dissection. So we advanced a SUA 03 wire without any need for contrast injection. This is the real-time fluoro, because you can appreciate the visual feedback that is strongly indicative of intraluminal progression with these soft tip guide wires. And then, of course, we had to stent. We put 2 long stents, and we achieved this final result. So this is what we had at the beginning, what we left, and what we achieved. So 3 different cases. The first one after 8 weeks, the real time. The second one after 6 months, and the third one after 5 days, 4 days. But it means that the investment procedure works and could be effective. So investment procedure is another tool that can be used as a primary step in successful treating challenging CTO. So before considering a failure, taking consideration to go on with an antegrade dissection and reentry strategy that it's now called investment procedure, the most important thing is to avoid stenting. Because if you implanted the stenting during the procedure, when you create such a large dissection, you can close all the fenestration that let the coronary to have a good TIMI flow and facilitating a healing of the dissection over time. And thank you for your attention.
Thank you very much, Gabriele. It's a very nice phenomena that you do it instead of failure, or just prepare the success of a next time. Dr. Sobhi.
What determined the remodeling in general? I mean, the vessel differs from me to you, the duration, the vessel size, the lesion. I don't know what are the parameters which determine the remodeling of the vessel.
You mean the remodeling?
Yes, because
Yeah, but okay, this is not really an issue during the investment procedure. I mean, the investment procedure is the second last step before considering to stop the procedure. So before considering a failure, you can go on with the antegrade dissection as a last bailout. And in this case, the negative remodeling of the distal vessel is not really an issue because you go through the dissection plane into the distal vessel. Thence, over time, you achieve a complete healing of the distal vessel, and maybe also the restoration of antegrade flow can also modify the negative remodeling, increasing the distal vessel diameter, and that could be also useful during the procedure in which you plan to put the stent.
Great. We'll take a couple of questions from audience.
Well, three very provocative cases. I mean, I just want to warn a bit the audience that before they do the same tomorrow for their occlusion. I mean, first of all, to say that we are dealing here with one of the best CD operators worldwide. Dr. Gasparini has 80–90% of success in a conventional true fashion or with limited subintimal tracking. So what he's telling us is for the remaining 10–20% where you are unsuccessful and you don't have a retrograde option, an alternative possibility. I think that's feasible, and you showed some fantastic example. Still, thanks to the fact that now we have a reliable wire built in for having a curve of around 8 millimeter that doesn't grow much more than that. The Gladius Mongo is my standard. At the end can even become a normal wire to track the true lumen, and you have shown also some beautiful examples also recently in Istanbul. The second point, always do under control lateral ingression, know what you are doing, don't advance wires in small branches that will achieve disasters. I think the only point and the only difficulty I have sometimes this patient, and the second case was an example of that, don't come back at the right time. And then what happens, they go to your neighbor, they say, what a disaster this valve does. And well, of course, I hope that now, from now on, all colleagues will behave fairly and understand this is a procedure that has potential of success.
Yeah, just you point out that the turning point in the recent time was the development of the Gladius Mongo. You are totally right. With the Gladius Mongo, you can have 100% of distal reentry. So it could be useful in investment procedure, but also in rescue star, in other vessel, in non-CTO PCI. So the Gladius Mongo is an excellent wire for knuckling.
Great. Last question, Dr. Hani.
Yeah, very briefly, while you're talking, I looked at the dictionary to find out what's a definition of investment. Investment in spending to have a reward. And you have done, you spend a lot of time and you get success. When I did the same with the hospital financial director, I said, why did your expenditure over the last 2 years quadrupled? I said, we do a lot of CTO. And I said, what are these 3–4 numbers? And I said, it's an investment procedure. He said, I'm pulling out my money from your department because this is not an investment. So that is his financial view, but the clinician differs considerably. My question to you, one, when do you call the procedure unsuccessful or failed? Is the first procedure or the second procedure? Because it's a procedure. And number two, when would you stop investing? Thank you.
Yeah, so of course, not always is possible to have an investment procedure. I mean, because sometimes, even if you spend time to dissect the vessel as a last step, you are not able maybe to reach the target because of sort of an unproximal or an unpenetrable proximal cap. I mean, sometimes you can consider a failure, the first procedure, if you are not able to go on with an investment procedure. Then, more or less, if you are able to do as a first procedure, the investment procedure, during the second procedure, in 90% of cases, you are able to put a stent and to find the same pathway. So, I mean, the failure could be considered at the first procedure and the second procedure as well. There are no data that I give you my personal rate.
Gabriele, I think there were two questions that sort of have the same ethos, if you may say. What is considered a good investment procedure in terms of, I wouldn't call it a successful, it's at the end of the day one way to mitigate a failure, but a good investment procedure, and Gabriele highlighted it quickly throughout the talk. A, that you are able to re-enter distally into the true lumen, and the Gladius Mongo is absolutely great in that, but in the previous days you would push the knuckle, it would remain in the subintimal space, and a consequent result is the TIMI flow grade. So if you're able to re-enter distally into the true lumen and have a TIMI3 flow at the end of the procedure, I think we consider this a good investment procedure. Otherwise, and the chances of having an open vessel 2 months down the line become significantly higher than 50%. If you lack one of those or lack both, the chances become lower. And I think you walk from the cath lab considering that this is a failed investment procedure. Would you agree, Gabriele?
I do agree. I think that the most important parameters to evaluate is the TIMI flow, but also the distal runoff. So in this case that I show you, it was 3 consecutive cases. I mean, I didn't select the best one to present you. It was because, of course, it's not so frequent situation. So I collected my 3 last cases. And so the TIMI flow and the distal runoff and all the branches were preserved. Of course, if I put a stent, I close all the fenestration and I achieve a TIMI 0 flow or TIMI 1, creating a sort of a cul-de-sac. So with avoiding stenting, all the fenestration led to have vascularization of the distal bed and all the side branch.
Gabriele, it's always a pleasure and honor to have you. Thank you very much, and it was a great presentation.
One important consideration about these extensive dissections, we did it for so many years, is that, as you notice, most of the cases presented deal with the right coronary artery, obtuse marginal branch, diagonal branches, circumflex posterolateral. If you do this approach for the LAD, is a total different scenario. Because when you create these dissections, the true lumen is almost non-existing anymore. You have communication between false lumen and true lumen, false lumen and true lumen. So even if you get a good distal wire, when you stent, and if you do that on the LAD, you're going to lose too many septals, and it becomes not a nice procedure because you end up with a very poor LAD. So I think these procedures and the STAR in general should only be done in the circ, but not in the LAD. If you do on the LAD, you have to do what they call anterograde dissection, and re-entry has to be something very, very short. But don't do investment procedure in the LAD.
Thank you very much, Gabriele.
You're welcome.
And we'll